welcome everyone. Thank you so much for carving out the time to be with us today. Thank you, thank you. So excited to have all of you on the meeting today with us. We have a fantastic presentation lined up with Dr. Alireza Sadr. We are so excited to hear from him. Just a couple of things I'll go over before we get started with the presentation today. If everyone could do me just one huge favor and go ahead and mute yourself. We'll ask that you stay muted for the duration of the presentation, just so that we don't interrupt the slides or the presentation. That would be great. Thank you so much in advance for that. My name is Carla Marshall. I am Executive Director for the Academy of Biomedic Dentistry, and I definitely do not do all of this alone. We have a fantastic board that assists us with everything behind the scenes. I'd like to introduce the board members for the Academy of Biomedic Dentistry. Dr. Mark Lazar, President, Dr. Saul Pressner, President-elect, Dr. Teresa Monson, Vendor Liaison, Dr. Joseph Sutton, Secretary, Dr. Michael Haney, Treasurer, Dr. Diane Caprio, Scientific Affairs, Dr. Paul O'Malley, Membership, Dr. Jim Erpenbach is a board member, Dr. Melissa Siebert, board member, Dr. Charles Rufinock, board member, Dr. Jay Resnick, board member. Thank you all of the board of directors for all of your help, and a special shout out and thank you to all of our scientific advisors who are on the call today. Thank you so much for your support. This webinar is being recorded. And so you will have a version of this after the meeting. We will send out an email with the recording. This is a part 1 of 2-part series with Dr. Alireza Sadr. Save the date and mark your calendar for our next webinar, Saturday, June 5th. We have mark your calendar for our next webinar. It'll be Saturday, June 5th at 4 p.m. We will not have a webinar on Memorial Day weekend. We will also be having a live question and answer at the end of today's presentation. So if you have a question during the presentation, please go ahead and just drop that in the chat bar. We will be answering all questions after the presentation. Today's webinar does offer CE credit. Our CE is provided by the Dental Digest, Dr. Melissa Siebert. Thank you very much, Dr. Siebert, for helping us with the CE. Once today's presentation is over, we will submit CE certificates via email through the Dental Digest. It'll come a few days after the webinar today, so watch your email for that. You will also need a code. After the presentation, we will give you the code. You'll need that to add to your certificate for the CE today. If you are unsure if you purchased CE, please just message me in the chat bar and I can check to make sure that you have purchased CE. CE must be purchased today during the webinar to be eligible for CE. We will not be able to honor any CE after today's webinar.
And we're also going to be doing 2 polls for the CE.
We'll be doing 2 polling questions for the CE today. Matt will go ahead and launch one of those polls right now for us. Pretty easy stuff. So just watch your screen, and when that pops up, go ahead and take the poll for us. Today's first polling question is, are you a current member of the Academy of Biomimetic Dentistry? Pretty easy, just clicking on that poll. We will have 1 poll also following the presentation today. If you are participating in CE, please make sure that you take that final polling question. We do ask that you stay for the duration of the presentation as well if you are requesting CE. With that, I will go ahead and hand things over to the President of the Academy of Biomimetic Dentistry, Dr. Mark Lazar.
Thank you, Carla. So today, I have the distinct pleasure of introducing the great Alireza Sadr. Dr. Sadr achieved his DDS degree from the National University of Iran and received a PhD for philosophy and dental science from TMDU. Dr. Sadr is an associate professor at the University of Washington and heads up a research team there and promotes the use of optical coherence tomography. Now, he has authored so many articles. He's authored almost 200, author or co-authored almost 200 full-length peer-review research articles, and he also lectures internationally. So he is extremely impressive. In fact, I've had the privilege of getting to know Alireza over the past few years, and I remember a few years back, we were actually lecturing at the same conference, and he spoke right before me. And I remember that he was so incredibly inspiring that I was modifying my entire lecture to include some of his thoughts and be able to quote him in my lecture, because it was that impressive. So Dr. Sadr has been a great friend and a mentor to all of us here at the Academy of Biomedic Dentistry. It's for this reason that we awarded him an honorary fellowship to the ABD, and also invited him to become a member of our distinguished group of scientific advisors. And we look forward to accomplishing some incredible things with him in the future by our side. So without further ado, I'd like to turn this webinar over to Dr. Alireza Sadr.
All right. Hello, good morning, good afternoon, and good evening, everyone. I'm really excited to have so many people here with us at the ABD online lecture series. Thank you, Dr. Lazar, for introducing. Thank you, Matthew and Carla, for your hard working, and thank you, Saul, for supporting ABD all along. So with this introduction, let's get to our presentation today. Okay, right. Do you have my full screen presentation?
Yep.
Okay, perfect. We did it right this time.
Yay.
So I'm going to talk a little bit about management of deep caries and caries in general. Maybe this lecture title is not exactly 100% in line with my slides. One thing that I learned from Japan is you got to talk about things that you know about, and the subject is much broader than what I have experienced. But basically, we're going to talk about diagnosis and management of deep caries. So with this, I have to declare my research sponsors. These are my sponsors, non-governmental, governmental, and industry sectors. With regard to that, there is no undisclosed conflicts of interest or financial interest in any of the products or the methods or clinical techniques that we talk about today. I started my journey in Iran with dental school, but I was born in UK, so I've practiced dentistry in both countries. I moved to Japan in 2003 and moved to University of Washington in 2015. So I put some numbers here. As Mark said, I have some publications and all that. And you know, when you go over, I guess, 100 publications, you start to think, what is the impact? Like, we've published a lot, but what is the impact? So I talk a little bit about that. There are some indices that Google Scholar has put on, like the H index. The H index is like how many citations you get for like the first number of papers. Like, say I have, for example, an H index of 45, means that I have 45 papers with at least 45 citations. So I don't know if that matters a lot. So here are some average H scores for different fields. But I'm not still very sure if the research that I've done over the past 20 years has been really impacting anything. It's just a number there. I see people have Instagram followers, and that looks like being a better way of measuring the impact. And I don't really have a lot of Instagram followers. So what I've done, basically, I would say bonding, non-invasive imaging, preventive, remineralization, and a lot of work in composite, gap formation, shrinkage stress, fiber reinforced composite, optical coherence tomography, and all that. And when I look at what I've done so far, is interesting. The #1 paper is about zirconia bonding. which is, we did a lot. Of course, everybody knows MDP bonds to zirconia, and that's the conclusion of the paper. But that sounds to be the most popular topic I've worked on, which is not my favorite topic. I would like to talk about bonding to the tooth. I would like to talk about preserving the tooth structure, but that's the reality of our practice out there. So since 2015, I've been the preclinical course director for operative dentistry training at UW, University of Washington. So I spend a lot of time with kids, if I may say. I hope they're not here, but with our young dental students, and you know, it's 5 operative dentistry quarters, so it's like 5 courses that we start operative dentistry A to Z. And it's been really fun. After working with graduate students for so many years, it's fun to work with pre-doctoral students and trying to convey the value of minimally invasive dentistry from day 0. So as a dental educator, here's what I do in terms of the references that we use: Art and Science of Operative Dentistry, Summit's Fundamental of Operative Dentistry. These are our main references, especially Summit's, which I really like as a book. I've heard that there are issues with coming up with the next edition. I hope Dr. Farrakhan and Dr. Hilton change their mind and kind of go ahead with a newer edition. But anyhow, we also refer to articles, we refer to Web of Science, so we wanna keep up to date with regard to what we teach. Again, some teaching tools here I've listed. Of course, these are all important. REB is still our main licensure path in Western United States. So we have to do that. But of course, there is now the OSCE exam, which is a non-clinical licensure exam. So some people decide to go that route, but that's not accepted in as many states. Anyhow, so we have to train our students in a way that they can, of course, pass REP. And I'm not sure if the cavity prep that I think is the right one would pass the board. So anyhow, again, I follow my students on Instagram. They really have great cases that they post on Instagram and all that. So this is great. So apart from that, I did my PhD in Tokyo Medical and Dental University. So TMDU has been really a great influence in my education. And I have listed some of the people there with great influence on the practice of dentistry. Of course, many of you know Professor Takao Fusayama. We're going to talk about caries affected and infected dentin a little bit from the clinical point of view and what he came up with in 1970s or maybe 60s. His paper in Japanese was in late 60s, talking about the differences that these two structures have and maybe the use of caries detector dye, something that is really helpful for our students even today to distinguish between caries infected and affected and kind of find that stop point. He also came up with the acid etching, total etching technique. I think Fusayama didn't have the right primer when he started to talk about etching dentin, which was a taboo at that time. Like people thought, oh, that's not possible. But anyhow, he started to investigate bonding to dentin earlier than many other researchers in the world. And he was the head of our department in Tokyo. Another figure is Dr. Junji Tagami. Professor Tagami was my supervisor. He has made great contributions to the practice of operative dentistry in the world. He was trained by Dr. Fusayama and Dr. Hosoda. So, and I think we had his lecture. So it's what I've learned from him and from Professor Fusayama have really shaped my philosophy practice. Here's Dr. Nakabayashi. He and I think David Pashley, they did a lot of work on the hybridization mechanism of dental tissue. So basically, the hybrid layer, if you have heard that term, is the idea that Nakabayashi came up with. So Dr. Nakabayashi is from a different department. He's not from Caryology and Operative Dentistry. And for me, and sort of insider, outsider, I respect both philosophies on the Caryology part and Institute of Biomaterials, where Dr. Nakabayashi was active in. So I respect both, and I consider all of them to be my senseis. Someone not really talked about here is Dr. Reichi Yamaga. Dr. Reichi Yamaga is the inventor of silver diamond fluoride that we're going to talk a little bit about today. I haven't heard a lot of people talking about him. He did this great invention in Osaka, but I have to say that Dr. Yamaga started his career in TMDU. So I take advantage of that and put him on this slide, even though if there are Osaka people here, they're going to be offended with this. Of course, he came up with SDF in that part of Japan, but he started in Tokyo, and that is what goes with silver diamond fluoride story. Okay, so, well, I've traveled a lot, as I said. I've practiced dentistry in 4 countries and seen dentistry from a very close angle of education and practice. But I've learned that mountains are beautiful. This is in north of Tehran, 18,000 feet. There is Fujisan, 12,000 in Tokyo. And here is our own Mount Rainier. I think they're gonna change the name. I don't know if you've heard of that. They're gonna change it back to a more local name, but anyhow, or at least that's a proposal. But this is our Washington State peak here. So minimally invasive dentistry, why does it even matter? So as we go ahead with evidence-based dentistry, and as we gain more knowledge of really high quality results about what is working and what is not working, and we ask clinical relevant questions in the PICO model, where we have certain patients, we look at certain interventions, make a comparison and look at the outcomes, we gain more and more good evidence on the advantages of evidence-based dentistry. And of course, the advantages of minimally invasive dentistry when it is measured by the evidence-based standards. And that's because we're looking at the outcomes, maybe from a different point of view. So restoration longevity is important, but what is more important than restoration longevity is the tooth longevity. So once you start to look at that point of view for our practice, you see that minimally invasive dentistry makes a lot of sense, right? So let's talk about caries a little. So this is the model that we have from many years ago. This is basically what I learned in a dental school. You know, it's a tooth, sugar, bacteria. So these are the factors that are effective in formation of decay, basically. Yeah? There is carbohydrate acid formation, bacterial fermentation, resulting in acid byproducts, and then there is caries, right? But when we look at what, say, Nivot, Kid, and Federoscope have talked about, you see what caries is much more complicated, and there are a lot of factors that are affecting it. There are, of course, personal factors, oral environmental factors, and there are direct factors. So we've only focused on the direct factors, but there is a larger circle of the factors that are affecting caries. And that is why I think minimally invasive dentistry would make a lot of sense when we look at it from a public health point of view as well. Of course, we have caries risk management, or Canberra system and all that. Today, we're learning more about how to deal with caries, which is the #1 oral health issue, still continues to be across the world. So when I teach it to the students, I try to teach them this way. Say what we're doing in conventional dentistry is like a vicious cycle. Oh, think of a cycle like a real bicycle, right? The circle of repair, detection, and disease, or say it's disease followed by detection, followed by repair, may not exactly work, because if you think of a bicycle that is getting always a flat tire, so you're riding your bicycle to the school, you get a flat tire once in a while, and then you repair it, right? If you don't look at the risk factor, which is maybe the road that you take to school, or protective factors, maybe the tire that's on your bicycle, you're gonna get lost in this circle, right? So maybe that is one way to look at how we're dealing with caries nowadays. It's sort of a vicious cycle. It is and basically excavation of caries and putting in some composite material in there, or glassonomer, or amalgam, right? Any of these materials. It does not necessarily break the cycle of caries formation. And that is one philosophical issue that I do have right now with the practice of dentistry. We have really focused on a lot of restorative dentistry, but I think when we talk about minimally invasive dentistry, biomimetic dentistry, we also need to look closer at how to break this cycle, right? Understanding the risk factors and understanding the protective factors. I'm going to talk a little bit about these concepts, but not much. So I think this is an interesting slide that we have from the ADA. So this is the ADA publication, kind of looking at the very basic principle in practice of dentistry, and that's diagnosis, right? I don't think we have a good consensus across the world on what is caries and when to treat. But what ADA put on their 2015 publication is looking at the initial lesions. These are the lesions, these are the carious lesions. We're looking at the tooth level, right? The initial lesions that we have there are those lesions that might show early signs of demineralization on enamel, right? They might have, and this is very important, look what they put on their initial, D1, right? They might have slight demineralization at the DEJ level. So bacteria is not there, but acids might have penetrated into dentin enamel lesion and dentin enamel junction, right? So of course, E1, E2, there's no cavitation here, there's no loss of surface here, but looking at the difference between initial and moderate, we can see what they put there is if you have a breakdown of enamel, which means that visible signs of cavitation, right? And dentin moderate demineralization, I think this is where we get really into the definition of bacterial penetration and infected dentin, right? So then that is where you really want to surgically cut the tooth structure. But before that, I think there are several factors affecting your decision in doing that, right? With D1, there is a lot of debate on what to do with D1 lesions if you look at it. But I think it's a clinical judgment question. And it's not that you should always go ahead and treat these lesions. These lesions, if you have, say, radiographs, the series of radiographs over time, and you look at lesion C that's always been there, right? Why would you even treat it? Or if you have, say, sealed this lesion interproximally with a product like Icon, right? I'm not going to talk about Icon today, but we're talking about caries infiltration concept, right? So if you have done that, or if someone else has done that, right, and you're not aware of it, the best way to deal with these types of lesions is to wait and watch them, right? And continue following them to see if they're progressing or not. Of course, you have to consider the caries risk of the patient, right? So another thing about minimally invasive dentistry is that sometimes when you look at an overhang, a restoration that is not following the standard. It's not ideal. It may create more issues, right? An overhang here, who knows that this overhang is not related to the caries lesion that we have here? Nobody can prove that. So I think another concept here is that a bad restoration is probably worse than no filling, right? If you look at the sealant works and the sealant studies, you also see that there are a lot of secondary caries issues around leaking sealants, and that's another thing. Like especially composite sealants, right? So we'll get to that. But anyhow, and less than standard dental work may damage the patient more than not doing it, right? Another concept in minimally invasive dentistry. Spiral dental treatments, I'm sure you've seen different versions of this concept here, but this is my version, right? So you start with a cavitated lesion, what say we have in ADA moderate lesion criteria, right? We have cavitation, we have evidence of infected dentin, right? Bacterial penetration, destruction of the collagen matrix or the organic structure, basically non-remineralizable dentin. You go ahead and you treat it, right? Now your treatment option is also very important in the fate of the tooth. You do say an adhesive restoration, go with round internal line angles, right? Preserve caries affected dentin, don't dig too deep, right? Or just looking at what we have here with the way things have changed. I hope nobody in this audience is doing the 1960s prep design or even pre-2000s prep design. We're going to focus on the lesion, right? Of course, we can talk about resistance and retention and all that. But if you're really dealing with a small occlusal lesion, there is really no reason to follow what GV Black was teaching us. I'm sure you know that, but just following. Or think of doing a GV Black restoration, right? So if it's a little bit deeper, and if you're throwing that tantrum that we sometimes do over removal of all soft dentin there, you're getting closer to the pulp. We're going to talk a little bit about that as well. And you may even expose the pulp, or the patient may come back after a while with exposure. Or these amalgams, they create cracks, right, over the long term. I think Dr. Ches went over that, and I'm going to talk about that a little next week. So you're closer to an endodontic lesion, right? An endodontic requirement, endodontic treatment. You go for endodontic treatment, then we know what the next story is, right? There is a crown because that's the best available evidence from not very high quality studies and not very good technology in restoring endodontically treated teeth. And then what's next? Yeah, usually in these teeth, you don't have a lot of walls remaining. You don't have enough ferrule, right? You think, okay, I'm gonna support my tooth with a post and a core and a crown. So that is the end of the tooth. I'm telling you, that is the end of the tooth. We've all seen this. We have seen this. We see it every day. Another reason to do minimally invasive dentistry. So let's talk a little bit about the treatment options that we have today. I want to make sure that every practitioner, if you're a practitioner in this audience, you're going to look at your toolbox. Look at your toolbox and make sure you have simple treatment options available in your toolbox. They may not necessarily be the income source of your practice. I really shouldn't get into economics, but I do. These are not the primary source of your practice, but these are really good practice builders, right? Because if you gain the trust of a patient, then they're going to come back to you for their life, right? So patient coming with a little bit of erosion, a little bit of hypersensitivity, a little bit of what we call non-carious cervical lesions. They're not very deep. Sometimes you can't even see them, right? Have you seen cervical hypersensitivity cases where you can't even really feel a huge, loss of dental tissue at the cervical area, but the patient is super sensitive. I have seen cases that there's like 0.5 millimeter or maybe less than that. What are we going to do for them? Does minimal invasive dentistry allow us to numb the patient up and create a trapezoid shaped, that's a University of Washington prep, trapezoid shaped class 5 and put composite in there? That's going to alleviate the sensitivity, yes, or maybe even an amalgam. But that's not the way that minimal invasive dentistry wants to do, right? So you could place a minimal invasive approach, could place desensitizer, like Bluma, right? Silver diamond fluoride, bioactive desensitizers, like toothmate desensitizer or Predicta gel, that's from Parkel. Or you could go with an invasive approach, right? Pulp test, irreversible pulpitis. If the tooth is so sensitive, most of the time your diagnosis is going to be irreversible pulpitis. And I don't think an endodontist would disagree. It's not in anybody's interest to disagree with this diagnosis, which I think is really primitive and retro, I would say, type of diagnosis for a pulpal disease. Go ahead, root canal, post-floor crown, and all that, right? So just wanted to touch on this. It's really, so this is a new thing. I think you should have a bioactive desensitizer in your toolbox. Every dentist that has a practice or practices dentistry, or every practice basically, I think it is good to have a bioactive desensitizer. And the bioactive desensitizers are based on nanohydroxyapatite or the TCP hydroxyapatite technologies, all right? So I don't want to really talk too much about products, but what we do in dentistry, we have products that we deal with. This is one of the papers we just published last year on how the nanohydroxyapatite-based desensitizer immediately creates a thick layer of mineral over exposed dentinal tissues. All right, here is a scanning electron microscope. All right, there are other brands. There is the Teethmate desensitizer. There are several nanohydroxyapatite based, or let's say mineral based. It doesn't have to be nanohydroxyapatite. It should be calcium based, right? Desensitizers, calcium phosphate based, or apatite based desensitizer out there in the market. Okay, you can review the articles. These ones I've worked on, they're really good ways to desensitize your patient. Most of the time, they immediately feel the result. I used to do bonding agents. I don't do bonding agents anymore because I have seen really good results with calcium phosphate base. I love these. Another thing you could do, you could apply this, and then if the patient's still sensitive, go ahead and do your bonding agent, your Bluma, or whatever you resin-based desensitizer you want to do. So this, really simple, really effective, and completely biomimetic and bioactive. And to now talk a little bit about the sealants. I want to talk about 10 minutes about the sealants and what we have probably not done quite right in the idea of placing sealants. All right. So sealants, Fissure sealants, are basically purposed for prevention, right? For prevention of caries formation. And they are highly indicated for younger patients. I don't say they're not indicated for adults, but let's talk about the younger patients where the tooth eruption may not be complete, right? So it goes into sort of a pediatric subject. But even with your adult patients, isolation is something that we really need for any type of composite that we do, a very good isolation. And I think this slide from Dr. No from GC, showing that if you have a half erupted tooth, are you really going to be able, at high risk of plaque formation, at high risk of caries formation under those sealants, under those fissures, are you really going to be able to apply a resin-based sealant effectively, right? This is I think it's a Saudi Arabian paper. I love this. It's so simple, but I just put it on all my presentations. Looking at the difference between resin sealants and Glassonomer-based sealants in dry and wet or saliva conditions. And they show very simply, I don't need a huge microscope or anything, that under presence of saliva, if you don't have a good isolation, your composite resin-based sealant, your resin sealant's not gonna work, right? So they have this not like leakage comparison, and basically, if you don't get a perfect sealant condition application, which is isolation, your resin-based sealant's gonna fail. Another thing about sealants is just basically looking at how deep they go, right? Resin-based sealant penetration by OCT. Okay, so this is a very nice paper that we published a few years ago. I'll talk a little bit more about OCT next week, but for those who are not familiar, OCT is just like ultrasonic imaging. So it's a diagnostic device, and what you do in OCT is you send a laser wave into the tooth structure, and you create a 3D image or a 2D image based on the reflection of the near infrared light from the tissue. So it is really nice technology for tooth imaging because it gives you 3D image and it gives you in-depth images, not like an ultrasound scanner where you only get the surface. So you get tomographic 3D image of the tooth structure, just like the ultrasonography. Of course, ultrasound, the older systems are 2D, but if you look at the new ones, they're 3D. So what we wanted to do was to look at the resin sealant penetration and see, even if you have a perfect isolation, can you really seal those fissures? So here's the publication. I think we came out in 2016. We did 3D images of the fissure, right? And then looked at the fissure basically after application of a resin-based sealant. You won't believe how many cases, and this is something you could do clinically. You could look at your fissure and then go ahead and apply the resin to find out that unfortunately, in a lot of cases, we do not have a complete penetration of the resin-based sealant into the fissure-based, right? So before, after, you're looking at a cross-section of the tooth, you can look at the structure of your fissure, and you could basically look at the penetration of the resin. And a lot of cases, when the fissure anatomy is the Coke bottle, what you know about, and we're going to talk about that in a minute, if we have that kind of anatomy, then it's impossible to get the resin down there, right? So, and this is what the microscopical issue. So you could do OCT and kind of do quality control on your sealants. Nobody wants to do that, right? But this one is in vitro. So when you look at the actual microscopical image, it is kind of disappointing. It is really disappointing, right? So whether it's Glassonomer sealant or resin-based sealant, it's really difficult to get a complete penetration, right? I want to refer to Dr. Rainey's publication here. Many years ago, he talked about this Coke bottle shape and the actual anatomy of the fissure, the way we thought it is and the way in reality it is. And I was kind of blown away when we did this OCT study because I could see these images published maybe 10, 15 or 20 years before we really came up with that clinical evaluation of thousands of fissures anatomy and finding that this is the more predominant type of fissure, right? So I want to open a parenthesis here. Air abrasion for sealants is probably a must, right? You look at minimally invasive dentistry, based on what we found with OCT, where it's very difficult to get a complete penetration into the fissure. It creates a very good tool and a very good modality for us to be able to open the fissure. So talking about that toolbox, we talked about bioactive desensitizers. The next thing a modern dentist want to have in their practice, if you don't have already, is some sort of air abrasion, micro etcher, whatever brand that there's AquaCare out there that has water flow as well. So all of these are great. You should have a precise tip to be able to kind of control your air abrasion and open up the fissures for a complete and successful penetration of the sealant. However, when we look at a lot of these sealants, we see that there is an increased chance of interfacial failure. This is without air abrasion, but even with abrasion, there is an increased chance of interfacial failure with aging. So basically, whether you're doing Glassonomer or you're doing a resin-based sealant, you have a higher chance of interfacial failure after a few years, after a few months. So what is the right thing to do in these cases? And that's what OCT shows. So here's your RMGI-based sealant, okay? We did phosphoric acid pre-treatment. It's very pretty clean enamel because this was polished enamel. And then after a couple of 100,000 cycles, you can see that the RMGI is debonding or separating from the enamel surface. That's not good news for a sealant, right? Because they fail locally. So the question here is, if we can't really seal with a sealant, then what we should do, right? So we did look at the nano indentation hardness around the sealants. And what I want to tell you here, I'm going to go quickly. If you have a resin modified glassonomer or a glassonomer-based sealant, you have advantages of increased hardness and increased acid resistance around the sealant. And that's a great thing, right? Because that's what we're looking for, the bioactivity and actual performance in protecting the tooth while we don't basically we might not have as long longevity as the resin sealant because glassonomer may come off easier, but you would have sustained effect of the glassonomer-based sealant. Okay, so here's how we did the nano indentation. We'll look at the very interface, let's say the edges of the sealant. We're looking at the edges of the sealant outside where we have, and that is, if you look at the fissure anatomy, you see a lot of times, it's not only at the base of the fissure, but these initial occlusal lesions are also sometimes spread over that entrance of the fissure. So, but just putting a resin over that is not going to remineralize it, or it's not going to really help in remineralization. So anyhow, this is the research sort of specimen preparation where we looked at the nano indentation at the edge and away from the edge by a few micrometers, right? So what we found here, I'm not going to get into this graph. What we found here is that there is advantage of the glassonomer-based sealant when compared to resin-based sealant in terms of the intermediate area and also in terms of the hardness of the demineralized area around our sealant. Okay, so yeah, 0.3 to 0.5 millimeter away from the sealed enamel in adjacent areas. So when we look at the effect or potential effect of fluoride release, and that's basically what we want to focus here when we talk about sealants, is that in artificial caries models that we'll look at, you get secondary caries. I don't know if it's secondary caries, maybe this is primary caries. We had this discussion with Journal of Dental Research reviewers, and we finally said caries forming around a restoration. It's not really a sealant, but sealants are very similar if you have enamel there. And you find a much less incidence of formation of lesion in this particular acid-based model, in vitro model, with application of a glassonomer. right? Now, I don't want to say that you should fill all the teeth with Glassonomer. That's not the point here. But what I'm trying to convey is if you're sealing enamel, you want to use a sealant that also has beneficial release of fluoride and antibacterial properties, okay? So Glassonomer, if you have high viscosity Glassonomer cement, they have a higher release of fluoride. We know that from GC data, Glassonomer versus resin, right? Another issue here is the effect of self-etching primers on enamel etching pattern. And the reality is that if you're using a self-etching primer for dentin, for enamel sealant, as say a fissure sealant, you're not really going to get enough etching effect. You're not going to get enough etching effect from a self-etching primer, the 7th generation all-in-one universal bond. So it is a good idea to use a bond, but if you use it without phosphoric acid, then you're not going to get enough etching effect. If you do use phosphoric acid, however, there is a chance of over-etching enamel, right? So that's another thing, another sort of issue that I have with resin-based sealants. So minimally invasive dentistry, look at what the polyacrylic acid can do there, look at what your air abrasion is going to give you, and then probably stay away from more damage to the enamel. Don't have a lot of evidence on that right now, but I have seen the hypermineralized layer of enamel being removed by phosphoric acid etching. For application of a sealant, that might be a little bit too aggressive. Okay, and here's what we see under the microscope. If you look at the phosphoric acid etched enamel, we're creating a say couple of micrometer deep zone of demineralization, right? And when we applied, when we subjected these samples to a caries model, this is where we got some caries formation. Okay, I know it's a little bit too much, but that's what we found in the lab. So polyacrylic acid etching for Glassonomer sounds to be not a bad idea, followed by air abrasion for sealants. Okay, so it might be a too harsh treatment, especially when it's young and immature enamel, right? Okay, so you may disagree, but this is out there. So we talked about the relationship between the minimally invasive dentistry, evidence-based dentistry, and the outcome measures, all right? So when you look at the retention studies, and this is a systematic review, comparing Glassonomer-based resin sealants and composite sealants or resin-based sealants. When you look at the retention, it's interesting that the resin-based sealants are favored by the majority of studies, right? So if you look at whether the sealants are remaining or not, especially in shorter term, 2 to 3 years, resin-based look to have a better retention. But when you look at the correct outcome, which is not the retention of the sealant, but is the caries incidence in a sort of parallel way, you can see that resin Glassonomer-based sealants have an advantage, right? So if you look at the outcome that is prevention of caries, you get a better result with the Glassonomer-based sealants. And in the longer term, you get an absolute better result with the Glassonomer-based sealants. Ignore your retention, because we also showed in the studies that once the Glassonomer comes off from enamel, you still have crystals attached and you still have a sustained effect, anti-caries effect of the Glassonomer with that fissure. So maybe we've not done a great job on promoting the right type of sealant over the years. So we can continue to talk about this subject because of the time. I'm going to skip talking about this, but we can go ahead and look at a very interesting study that was published on the incidence of primary molar caries after application of Glassonomer-based sealants on the adjacent permanent tooth. And they actually found that there is a lower incidence of caries on the proximal of the primary molars when a Glassonomer cement was chosen as the sealant. That is really interesting. Three-year study in Italy. So, and to summarize this discussion, here we have better comparing resin-based sealants and Glassonomer-based sealants in terms of the sealing effect and retention. If you do proper application of the resin, it's great retention. We have no doubt about that. Glassonomer could be a little bit inferior in terms of the retention. You may or may not have a fluoride releasing resin, but you could have, of course, any type of Glassonomer will have fluoride release. There are differences between them, but almost any type of Glassonomer will beat resin, even if they are meant to be fluoride releasing. There is no moisture tolerance for resin-based. So if you have the operculum, if you have half erupted tooth, then the question is composite-based sealant isn't even an option. And they have both literature support there. So let's talk a little bit about caries tissue removal here. So I'm going to talk about bonding, fiber reinforced composite, reconstruction of the tooth next time. But let me talk a little bit about what we have consensus over today for management of deep caries lesion. Okay, so now you're beyond the sealant, whatever sealant failed, or there wasn't even a sealant, and you're dealing with a patient with deep caries lesions, or there is high caries, for whatever reason. This is sort of a conclusion slide, but what I want to say is that I truly believe that this is management recommendation based on the latest and the best evidence and the minimally invasive dentistry today. Okay, preserving the healthy tissue, achieving a restorative seal, maintaining pulpal health, maximizing restoration success, that again, we're going to talk about it later, and preserving the pulpal health are the priorities in treatment of deep caries lesion. Okay, so I'm sure everybody believes in it, or at least everybody has heard about it. But once we get into that clinical setting, I still see that we have issues with prioritizing pulpal health over complete caries removal in deep caries cases. All right. Especially, so I'm going to bring a dilemma here. I always bring from this. If you have an asymptomatic tooth with deep caries, all right, deep occlusal caries, it's asymptomatic. There are no pulpal issues. If that patient leaves your office with a referral to endo, that is not the best standard of care that you're applying. So we must always preserve the pulpal health and prioritize it over complete caries removal. Okay. So again, I'm from Tokyo Medical and Dental University. So this is how I was taught by Professor Tagami in TMDU. So we're gonna kind of take a look at the definition of caries. I think this is a slide by Kusayama. When they started to really look at different structure of the caries tissue in deep caries or in caries dentin, basically, right? And I'm sure you've heard that classification between the stained dentin and non-stained dentin, and the zones that are there, and normal dentin, and caries affected, and infected dentin. So a quick recap of what these classifications are. We have a zone of slightly or moderately demineralized dentin with remineralizable or with pretty sound organic structure beneath caries infected or beneath the outer lesion in dentin that can be preserved. Okay, so that's the whole idea. If you're dealing with the deep caries, you can leave a little soft dentin or even more than a little soft dentin down there to preserve the health of the pulp, right? And I think this is Professor Tagami's thesis also, when he looked at the sensitivity and the mechanism of sensitivity in deep caries. And I think he's got this very nice signature slide. Let's go ahead. Where he shows that the bacterial front and discoloration front are apart from each other. Bacterial front is way shallower. You go by discoloration, of course, you're going to see a deeper. And if you go just by hardness and softness, you can get very close to the pulpal tissue, right? But transparent dentin formation, this has been a subject to debate. But what we know that the softening front is usually much deeper than the discoloration front and should not be exactly the basis for our caries removal. Okay, so the clinical case of caries detector dye use can help you in removing the caries, right? Whether you're going to do a lining or not. But let's look at the permeability. So what Tagami showed in this slide is striking, showing that if you have caries affected dentin, which is showing a lower permeability than sound dentin because of the precipitation of minerals as a result of continued de and remineralization, then you have actually less permeability, right? Less permeability. So he is injecting the dye here from the pulpal side and looking at filtration of the solution through the pulp. What he finds is that the area which is slightly discolored and identified as caries affected dentin, it is softer. It is softer than normal dentin. It is significantly softer than normal dentin. Then you can find much less permeability, and this will prevent, what does it gonna do? It's gonna protect your pulp because it is totally low permeability. So it will help you keep the pulpal health. Okay, and then they looked at, I haven't been able to find a lot of these casts, mineral casts beneath the caries affected dentin. So I've looked at scanning electron microscope images. I think this slide is great because they found a lot of them here. So what we did a couple of years ago is we repeated Fusayama's study here, but this time, instead of using the hardness based on the noob hardness, which is sort of a crude measure, we use nano indentation. So we have this very small indenter with a couple of micrometers sort of head. And we tried to distinguish the intertubular dentin from the dentinal tubules and the peritubular dentin. I know if you've read Summit's book or any other operative book, they talk about the peritubular dentin having a higher mineral content, having lower organic content, and basically being more resistant to etching. And what the noob hardness shows you, and based on Fusayama's studies, shows that, of course, the caries affected dentin is softer than normal dentin, but it has some relative hardness, right? That can be a good guide for removal of caries. So I don't know if anybody has read this article. This is by Gerardo Hofes, published in Dental Materials Journal. So we will look at the caries affected dentin. The results were striking for me. we did actually two types of caries affected dentin. We did the artificial caries affected dentin, which is based on an acid-based model. It's basically in vitro demineralization of dentin with pH cycles based on a protocol that we have to create sort of artificial caries affected dentin. And we took a number of natural caries affected dentin, a natural carious teeth, recently extracted, and we tried to get them to the test as soon as possible. And this is what the result is. It is very interesting. There is only one peak of hardness in deep caries. There is one peak of nano indentation hardness within the intertubular dentin. And if you miss that peak, then it's going to get softer and softer and softer. Now, can we understand the reason why we come up with pulpal exposures? Just because we go based off the hardness. So I think one one message that I can give you from this particular study was that do not expect to reach hard dentin or even sometimes relatively hard dentin as you're removing deep caries in a deep caries tooth, okay? So natural caries affected dentin is way softer based on the nano indentation. So if you measure the hardness within intertubular dentin, okay, each of the indenters is about a micrometer or 2 micrometers in size, then we can see that it's pretty much soft. It is again in line with what Husayama said regarding the demineralization of the collagen structure or the organic structure, matrix being there, but mineral being lost, but still there is the whole structure of dentin is not completely disrupted. Okay, so what are we gonna do if I'm gonna leave that much of decay on a deep caries lesion? So I think everybody agrees that this is not about the periphery of your perforation. I'm not talking about the periphery of your perforation. I'm talking about deep caries areas over the pulpal structure. Okay, so let's talk a little bit about silver diamond fluoride here. Okay, so silver diamond fluoride, as I mentioned, is something that Reichi Yamaga came up with in 1960s and 70s. So it's 38%. There are several percentages. The most common across the world is the 38% or 44,800 ppm fluoride solution with silver, right? So I'm not going to get into the chemical composition here, but there is 220,000 ppm of ammonial silver there. And I think Yamaga was sort of inspired by the Ohaguro, that's the tooth blackening tradition in Japan. And that's what he writes in his book about the Edo period with 1600 to 1800, where married women in Japan used to dye their teeth black using a tannin-rich tree powder and, of course, ferrous acetate. So what he found and what he knew from then was that the women that blackened their teeth traditionally in Japan had a lower incidence of caries. And if you look at the very old Japanese literature, say that ohaguro, which is blackening of the tooth, would prevent tooth decay. And there is actual archaeological and historical evidence on that. When I think in Nagasaki University, they looked at the modern samurai and commoners, which in some samurais had a little bit of tooth blackening, and also females against males, because it was more common among the females. So they found that those who had tooth blackening had a lower incidence of caries. So this is Yamaga CV again, because he's not as well known. I thought it's fair to spread this knowledge. 9050 in TMDU, 16 Osaka, 79 he retired. So he was not a dentist, but he had looked at the incidence of caries pattern in Japan and found out that after the war, when there was the sort of shortage of food supplies in Japan until mid 40s, then the incidence of caries had fallen. But with Japan becoming industrial and dominated by the Western culture in post-war era, the sugar consumption keeps going up, and so does the incidence of caries among elementary school children. And that is the reason he brings in his book for following sort of something like silver diamond fluoride as a way to fight this rapid increase of caries in Japan. So I should mention that Shofu Company has done a lot of work on sort of continuing what Yamaga did, and they came up with the SPRG filler and all that in the composites, and that's something I don't want to talk about today, but just wanted to mention that they also marketed the HY agent, another thing that the Yamaga had developed, the high bond for as a sort of glass ornament. They actually showed that the bond strength of glass ionomer increases with application of silver diamond fluoride to dentin. So that is something that we are right now also kind of looking at, saying that if glass ionomer would benefit from application of SDF in terms of the bond strength, but we know that there are other advantages that I will go over. So this is a translation of the proposed mechanism of SDF. So this is how an engineer kind of approaches issues. So he says, okay, there is silver, there is fluoride. Silver is going to work over the proteins as well as bacteria. Fluoride is going to interact with both inorganic and organic substances. Especially, it's going to the fluoride is going to interact with calcium, and it's going to have all these actions. Okay, so let's see what he put when he invented this material over the expected clinical effectiveness. He said it's going to do caries prevention, caries arrestment, inhibition of secondary caries, root canal treatment, protection of pulpal tissue, and desensitizing. This is 9071 diagram and published in 1996 again in Tokyo. So this is what his expectations are. Do we have enough evidence on all of these? We have evidence on some, we don't have evidence on others, okay? So we know, and unfortunately, the Japanese didn't really do a full-scale clinical trial by today's standard. They have a lot of clinical data gathering, but they really never did those meta-analysis that we like to see in evidence-based dentistry. But they showed that it has a good desensitizing effect. They showed that it has a good caries prevention effect compared to silver nitrate. And I think silver nitrate and fluoride was kind of the inspiration of silver diamond fluoride, because we knew that silver nitrate, of course, in the United States was a popular caries arresting agent, even then, prior to introduction of silver diamond fluoride in Japan. So again, 9070 in Japan, and pediatric dentistry cases that I talked to my colleagues in Japan, rampant caries cases are not really that much seen in Japan. And that's why SDF is not as popular as it used to be. I know Dr. Tagami said that he uses it as sort of caries detector dye, where if you don't have the caries detector dyes, or if you want something that has some benefits, you could use SDF instead of a caries detector dye. That's an interesting idea. But anyhow, these are the reasons why the Japanese have kind of departed from the SDF. And as I said, Shofu has developed their own antibacterial, fluoride releasing, and of course, strontium releasing kind of composite. And GC has also worked on that, a bioactive sort of glassonomer that releases metal-based ions. And we're not going to talk about that, but anyhow, these are the reasons that SDF is not as popular in Japan anymore. But in 2016, I believe, yes, they came out with the root caries management kind of clinical protocol. And in this Japanese article, which is from the Japanese Journal of Conservative Dentistry, and also published in English, they say that SDF is still recommended for non-invasive treatment and prevention of root caries in the elderly, and can be effective to improve overall oral environment. And by that, it's because of the antibacterial effect of the silver ammonia in the SDF that will improve overall oral environment for root caries cases, for elderly, for those who are sort of difficult to control with conventional dentistry. So we did an effort. So the main disadvantage of silver diamond fluoride, or at least one of the disadvantages, is the discoloration. That I'll talk a little bit about a way to tackle it. Many of you may know about that. But we did try to look at different ions instead of silver. So look at zinc, and that is what, again, GC is looking at. Instead of silver, because the metallic silver is what causes the discoloration. So if we come up with a formulation that has a non-discoloring metallic ion such as zinc with antibacterial properties, can we get the same effect as silver diamond fluoride? And it's interesting that we didn't get as good effect with zinc. We got some effect, but we didn't get as much effect as silver diamond fluoride. Here is silver diamond fluoride applied over the dentin, and dentin exposed to caries challenge. Here's control if you didn't have any. This is a this is a transverse microradiography technique, where you look at a very thin cross-section of dentin. And what we found was that SDF has an absolutely unbeatable root caries arresting and prevention effect when we compare it to the APF, zinc fluoride, or other types of fluoride. This is not exactly a clinical trial, but this is what Dr. Kubo did in Nagasaki University. Again, they have a great interest in silver diamond fluoride. And so looks like they applied SDF at the baseline here on this lateral tooth, an elderly patient. I think it was 68 or 69-year-old, and then not on the adjacent. I believe this is a number 8, right? So let's take it at number 7 or 8. I don't know, maybe 10 and 9. So they went ahead and followed up this case for 6 years. And it's interesting, after 6 years where there was an increased issue with the xerostomia, so dry mouth in this particular case, you see that there is obvious caries formation around the central incisor. Well, the area that was treated with silver diamond fluoride, and I think this was an annual application of SDF, was completely intact. So I hope this is a good way to kind of look at the potential effects of silver diamond fluoride on root caries prevention, especially for the elderly. So this is the case that I was promising to talk about. What do we do with these cases, right? Of course, we can't go ahead and do composites there. And I did not feel very comfortable just putting Glassonomer. So this is the case that we published in Operative Dentistry in 2016. Patient comes, looks like a met mouth to me. They deny it, but looks like a met mouth issue. Young patient, lots of issues socially because of the appearance of the teeth. They want things done. As you can see, the gingival health is not great. So one of the could you please go ahead and mute yourself? Okay, thank you. So one of the issues that we have with these cases is, of course, where to start from. What are we going to do with them? Conventional dentistry. The other issue is that they're very close to the pulp. All of these are close to the pulp. And caries management and basically reduction of the risk is another issue here. What are we going to do to boost the patient's confidence so that they can go out and kind of resume their social life? But we also want to preserve the teeth as far as possible, and we want it to be fast and effective. We are dealing with infection here. So I think silver diamond fluoride is, so here is the clinical technique that was published in 2019. One of the ways that we can tackle these kind of cases is with the silver diamond fluoride. So what we just cleaned up very lightly. Why do we clean up here lightly? Because we of course want to remove the biofilm as much as possible here. You could use air abrasion in these cases, but you've got to be very careful with the potential exposure of the pulp because it could happen very fast. We just took a manual instrument, cleaned up the edges a little bit with a round burr, and we went ahead and applied our silver diamond fluoride. And because I said silver diamond fluoride results in discoloration of the dentin, we also followed this application by potassium iodide. And let me talk a little bit about potassium iodide, because this case was basically a report on the potential advantage of using potassium iodide with following the silver diamond fluoride. And then replace Glassonomer, let the patient go. As you can see, there is a little bit of yellowness around the margins here, which is, I think, because of the precipitate that potassium iodide creates with SDF. But this is, in general, a way better appearance than having applied silver diamond fluoride without potassium iodide. There is one thing I want to recommend here. If you have to use silver diamond fluoride because of its advantages in terms of antibacterial and remineralization effects, and it's an anterior tooth, it's best to use a conventional Glassonomer. And the reason is that the light curing of the material over SDF treated dentin increases the chance of discoloration. So if you can stay away from a material that needs light curing, you have reduced the chance of discoloration by a lot. And of course, use of potassium iodide is another way to do that. There is a product out there, Rivistar, where it will have its own antimicrobial effects, and it creates a white precipitate with SDF, so it will decrease the dark staining, and you can basically wash off that precipitate that is created with the potassium iodide and silver diamond fluoride. Now, people ask, can we, so here is the discoloration that you could expect from SDF. People ask, if we don't have Rivistar, are there ways that we can decrease the discoloration? Yes, you could use your silver diamond fluoride and get a potassium iodide from a different source. Now, there are potassium iodide sort of sold in pharmacies and all that. So I can't really recommend that, but that is one approach to reduce the SDF staining if you don't have access to Rivistar. But Rivistar is, of course, a system that has SDF as one step and potassium iodide as a second step. So people ask a lot about bonding to SDF treated dentin. What if I have a deep caries and I go ahead and apply silver diamond fluoride, and now I want to bond to it? I just don't want to use Glassonomer for whatever reason that I have. What is the best protocol to bond to silver diamond fluoride treated dentin? And this is a study we did in 2018, published in Dental Materials again. We looked at the bond strength of two different bonding agents. So we have Scotch Bond Universal and we have Clearfill SE Bond. And we did Scotch Bond Universal in the self-etch mode and the total etch mode, so with phosphoric acid etching. And then we have the Clearfill SE Bond, of course, two-step gold standard of 6th generation adhesives that we'll talk a little bit about next week. So we found that both total etching of dentin and use of the two-step self-etch was effective after rinsing of the silver diamond fluoride off. So here is a very important point, because if you look at the American SDF, which is by Elevate Oral Care, in the instructions, it doesn't talk about rinsing, but you have to rinse. Even if you're leaving the SDF, I highly recommend that you rinse off the SDF after 2 to 3 minutes, okay? Wait 2 to 3 minutes and rinse it off, just don't leave it there. It's also because of the potential of penetration of the silver and fluoride ions into the pulp, right? So you wanna rinse it off. After you completely rinse it off, you could use total etching technique or a two-step self-etch. But it was way better if we could remove the superficial discolored dentin. We could get a much better bond strength. But the reality is that this was done on sound dentin, right? And that is really not the clinical substrate that we usually have when we're bonding to SDF treated dentin. Usually our clinical substrate is caries affected or even infected dentin. And I highly recommend that you look at Glassonomer for covering of the SDF treated dentin. If you go ahead with the bonding agent, I think using a total etching technique, even though I totally believe in self-etching technique, but if you're dealing with silver diamond fluoride, because of the alkaline nature of this material, you do want to bond, definitely do a total etch, do a phosphoric acid cleaning before you go ahead with application of your bonding agent. So here is this patient coming back after 6 months. So we went ahead and applied good composite, little bit better than what it was. And well, it's a student case. Sorry, it doesn't look great. Mark, I'm sorry that it doesn't look like your veneer works, but the patient was happy. And again, look at the health of the gingiva, how the inflammation has decreased, how, again, this is just right after application. This is a couple of months later. And, you know, if you can give this service to a patient, I'm not sure if everybody has this type of patient in their practices, but if you do, this is a great way to improve their health. So are you going to use SDF with KI or not? These are all clinical judgments. I'm just going to go with Glassonomer, the ART technique that has been around for many years. We know about it, but we wanted to use something sort of bioactive in this case. So the last study that I want to introduce is the way that we looked at the potential benefit of silver diamond fluoride application with Glassonomer on very deep dentin caries without any caries removal. So here we're talking about even leaving the infected dentin in there. Just do a very quick cleanup. Do not remove too much of dentin. And I don't have 100% well-established protocol to tell you about that, because I have also seen disadvantages of removing carious dentin with SDF, because as you remove the carious dentin, you're getting closer to the pulp. So are you increasing the chance of SDF getting into the pulp? That is something you definitely want to consider. So if you are going to use SDF, do not remove as much as you would as if you were just doing a bonding agent. So here what we did, we applied the silver diamond fluoride over just cavitated lesions, advanced by ADA criteria, advanced lesions. We applied silver diamond fluoride, and we reapplied after 1 week in one group. We applied Glassonomer immediately in the other group, and then we applied Glassonomer after 2 applications of SDF in another group, and kind of looked at the reaction of totally infected dentin to the combination of silver diamond fluoride here and Glassonomer. This is done with the micro CT technology. It's a great way of looking at the mineral content. And what we wanted to find out was, first of all, is it true that Glassonomer improves the effectiveness of SDF? Second of all, what is the right frequency of SDF application before we go ahead and apply Glassonomer? Just gonna get to the results, and we looked at 2 different measures. We looked at the lesion depth, and we look at the mineral loss. Now, the lesion depth doesn't really change a lot if you know the microradiography technique of measuring the lesion depth. The lesion depth doesn't really change a lot with SDF or even Glassonomer application. The reason is that some demineralization will remain, but it's all about rehardening the dentin. So let's look at the mineral loss with the Glassonomer control and with the just no application control. What we found was that Glassonomer alone here, Glassonomer alone was not as good as Glassonomer and SDF. So SDF actually improved mineral gain. Yeah, the opposite of mineral loss. Improved mineral gain with application of the SDF. So SDF plus GI, a very good method for improving the mineral gain with super deep Caries lesions. All right. And what we also found was that if you apply SDF 2 times, which means that you apply it, say week 1, and you let the patient go, you don't put anything on top of it, and the patient comes back after say 1 to 2 weeks, and you reapply the SDF, and now you go ahead and apply your Glassonomer, you have a much better result than just single application of SDF. But we also showed that 3 applications of SDF does not have an increased advantage over 2 applications. So I think based on this, not 100% clinical trials, because these are extracted teeth stored in artificial saliva, we could find that single or double application of silver diamond fluoride prior to placement of Glassonomer cement improved mineral gain by dentin significantly over SDF alone or over Glassonomer alone. Okay, so we talked about the staining, we talked about the application of potassium iodide, and here is a scanning electron microscope looking at the bonded interface. Again, if you're going to bond, as I said, you have to rinse off the SDF after application, even in the Glassonomer or in the bonded interface cases. You don't want precipitation of SDF and especially precipitation of the silver over the dentin surface. So please do wash off SDF after application. So potassium iodide, here's some information. I can repeat that. You could get it from Sigma Aldrich, but it's very simple to make. You just get the potassium iodide and you add it to deionized water, but I don't think you can use it clinically. This is just an experimental protocol. If you want to use it clinically, you got to get it either from the Upshur Smith Labs. It's a solution that is commercially available as a oral solution, or you can get the Rivastar product. So people also ask about potassium iodide and SDF. Unfortunately, if you apply potassium iodide after silver diamond fluoride, it is very hard to bond to that kind of dentin. So if your plan is to use adhesive right after application of SDF, do not even think of doing potassium iodide because it creates a creamy precipitate, which is so difficult to remove. So unless you have a plan to physically remove dentin after potassium iodide, you won't be able to bond to that structure. And this is what we published last year in Journal of American Journal of Dentistry. Okay, so you see here the bond strength to SDF Ki treated dentin, even with phosphoric acid etching, was not great. It was very good with the SDF only after the phosphoric acid etch, but we didn't get good enough bonding with potassium iodide treated dentin. This is one of my patients. I've lost him, I think, because of maybe cancer, because I haven't heard, and I'm afraid of calling them back and see what they're doing because they had advanced squamous cell carcinoma when I saw them, and I actually saw him with Peter Milgram from University of Washington a few years ago, and we started. I mean, he was told that you have to take all the teeth out, but he didn't want to do that, and SDF helped us with this radiation therapy, chemotherapy, and surgical cancer removal case, keep their teeth until they were around. So very good way of providing service to the population with silver diamond fluoride. I did go ahead once in a while. I saw this patient. I said, okay, now you're here. Can I apply some Glassonomer over some of these lesions? And we did improve over a few years. But I would say this case was probably something around 15 years or maybe 12 years of extended tooth life with just doing SDF. Okay, so people ask a lot about pulp capping and what about that? So if you follow what we said in terms of the advantage and the importance of keeping dentin over healthy pulp, and different ways of restoring a tooth, even leaving some caries behind because you are prioritizing pulpal health, this should not really apply. Okay, we know that the evidence on direct pulp capping is not as good as indirect pulp capping. Now you want to call it a base, a liner, close sandwich technique, whatever you look at there, the best pulp capping material is dentin itself. So just leave, even if it's affected dentin, right? Even if it's infected dentin, you could go ahead, remove less, and apply an antibacterial material like silver diamond fluoride. But now, because people ask about direct pulp capping, let's just review what is out there in 2 very short slides. Calcium hydroxide, Dical and all that, they are just out of question. They are out of question by today's standard. MTA, mineral trioxide aggregate, has way stronger evidence from multiple systematic reviews over calcium hydroxide cement for direct pulp capping. Okay, again, I don't do direct pulp cap that much because I tend not to expose the pulp, and I don't believe in caries exposure. If there is really bacteria into the pulp, then that needs an endo, right? And pulpotomy is one option, but talking about exposures here, MTA is great. Things like Biodentin, calcium silicate-based cements and all that, there is not enough evidence, but we can see that these types of materials are showing comparable results at this point to MTA. They may have an advantage of working time and also setting time, basically, because MTA is a little bit slow to set. And maybe you can put them in a bulk. These calcium silicates means you can put them in a bulk, but you can't put MTA as a bulk. You could do some composite over the Biodentin if you're directly pulp capping. So the best available evidence here on direct pulp capping, this is the last thing I wanted to talk about, is the MTA has advantages that are proven in all the textbooks over Dical. So we still use Dical in our clinics, but I never use Dical. It doesn't have an application in my dentistry because if I have to do pulp capping, I'm gonna go with MTA. Use of Biodentin and similar products need further studies, but the initial results are very positive with them. And here is something that we've talked about in the past years. So as the more evidence is coming out on direct application of adhesive systems over the pulp, exposed pulp, not talking about indirect pulp cap. Indirect pulp cap doesn't matter. You can use anything there as long as you create a good seal, right? But if you are dealing with exposed pulp, the adhesives are not recommended because of potential damage to the pulp tissue. For those who don't know much about the Biodentin, here is a case. In this case, they recommended the use of a little bit of fibrin over the pulpotomy, and then fill it with this Biodentin cement, which is calcium silicate, and put a composite on top of that and follow up for a year. I think this is more an endodontic subject, but just wanted to make sure that we have sort of covered everything from sealants down to very deep caries. So these are some of the things I'm going to talk about next week. I'm going to tell you the story of this patient that had only a remaining root and how I built up a tooth that I think will last her forever. Well, the tooth will last her forever. I don't know if the crown will. I'm going to talk to you about our latest research on placing fiber in deep preparations. What is the best way to get a good adaptation without a lot of void? And of course, I'm going to talk about fiber reinforced composite effects on shrinkage affected cavities and on distribution of forces in a cavity. So thank you very much for your attention. I'm here to answer any questions that you may have.
All right. That was awesome. I love the storytelling. Such great stories. And I'm looking forward to next week. So I remember, Dr. Ali, when we did our little teaser video interview, I was asking you what are the stories you're going to be sharing with everybody. As you got to show these stories. So I'm happy you threw them in there. Really great stuff. Hopefully everybody enjoyed it. The wonderful one and only Carla Marshall had to, our executive director had to step away. So I'm going to be going through a few housekeeping things here with everybody. Please stick around. The first thing that's I'm going to do first is the poll. So if you guys and gals are wanting CE credit, you do have to do our poll. So let me just start that now so we can get that out of the way. It's a very difficult question, as all of our polling questions are. So if you need help, just let me know. This one might be a little tricky. Let's see if you guys can get it. Okay, I'm gonna launch the poll right now. So you should see it. So fill that out for me. I'll let it sit for about 30 seconds, maybe 45 seconds. Great presentation, Dr. Sadr. It was awesome. I'm sure people loved it. All right, I'll just let this go for a little bit longer. Looks like most people are getting it right. Yeah.
Miami, I wish.
There is a couple of Miamis coming through. Yeah.
Chicago, not that much.
All right, so I'm going to end this poll now. And while we're doing the poll, if you are getting CE credit, that will be coming from Dr. Melissa Siebert over at Dental Digest. You will be getting an email we have to export the list out of our Zoom. We have to do a cross-reference to the people who purchased the CE credit. Then we're going to send it over to Dr. Siebert, and then she's going to be emailing everyone. So it usually takes 2 to 4 days, 2 to 5 days just to get that out to everyone. So if you have any issues, if you don't see that in your inbox, please check your spam folder as well, because that has happened a couple times. Or just contact us at the Academy and we'll take a look as well. Okay, I'm going to end the poll. All right. And the next thing I want to just discuss is Dr. Sadr was alluding to the next webinar. Now, normally we do them every 2 weeks, but in 2 weeks from now in the USA, it's a holiday. So we're doing it in 3 weeks. So that is going to be, I believe, June 5th. Let me just pull up the slide so we can all confirm that that is the correct date and time. Yep. June 5th, 4 p.m. Eastern New York time. Is this the correct subject matter, Doctor?
I hope so. We'll figure out.
Yeah. All right. While we're also covering CE credit, this is where it will be coming from, Dr. Melissa Siebert of Dental Digest. And also you are going to be needing this code. So I'll leave this up for a little bit and I'll also put it in the chat. If you could take a screenshot or write that down, you are going to need that for when you are submitting or filling out the form for the CE. We are also offering a $10 off coupon for today only for anybody that wants to join us for Dr. Sadr's next webinar. The next webinar is going to be $70 for the webinar. It is a paid webinar on this subject right here. And the CE is $25. But if you purchase that today, we've got a $10 off coupon. Let me just pull up that coupon, take a screenshot of that. Nope, that's the CE code. Here we go. There it is, ABD10. This is going to be good until midnight Pacific time today. So we just want to kind of get you guys in there now. So get it out of the way and start filling our list. Okay, so I've covered that. The next thing we want to discuss, this is going to be a little bit about the Academy of Biomimetic Dentistry. I'll probably take about 5 minutes just to review our website, let you know what we do. Dr. Mark Lazar is on here. He'll probably talk a little bit about it. He's our acting president right now. Hey, Mark, how are you? So let me share my screen for our website. If you have any questions regarding memberships or website or accreditations or things like that, that usually comes from either myself or Carla, who is not here right now, but she's usually, her or me are usually the ones behind the emails and the text communications and phone calls with everybody. Let me find my screen. Here it is. Okay, so here's our wonderful Academy of Biomimetic Dentistry website. One of the best things about being a member is we do have basically everybody on we kind of went through this earlier, we have everybody and we're always looking for more scientific advisors to help further the message of biomimetic dentistry. I know we've got many of these people. I saw Ray on here as well earlier. Hey, Ray. And so we've got a lot of our biomimetic scientific advisors showing up. I know Dr. Rudo is on here as well. And look at that, Dr. Sadr, you're in the first spot for today. So I wanted to just make sure that everyone knew that it's a great community and we're growing fast and we're always looking for, it's a global community. We're always looking for more dentists who want to further the message of biomimetic dentistry. So some of the things that are included with your membership, one of the best things is our Find a Biomimetic search tool right here, because the word is really getting out there about what biomimetic dentistry is. And we get a lot of traffic to the website and people are always looking for a biomimetic dentist. And there are still a lot of gaps in the country and in the world where there just aren't biomimetic dentists. So we need you guys and practitioners and girls to build our database so that we can actually, get the help people like me who aren't dentists to get Biomedic dentistry. So that's one of the best things that we do offer that comes with it. We also have a wonderful membership level. Wonderful membership. So there is a portal right here to sign in, and inside the portal, you'll have access to all your webinar recordings and educational case studies, and we're constantly adding new and better stuff to that. And we've got some of our scientific advisors creating great stuff for the membership portal as well. So it's really wonderful, and we're constantly innovating and trying to get new and good stuff in there. We also offer accreditations and fellowship programs. So if I go here for dentists and I go to certification programs, there it is. Dr. Mark Lazar and Dr. Paul O'Malley worked really hard to get this done, and this is one of the best things that the Academy has done. So you now can become an accredited member. This right here, is it the general pledge? This is free, and it actually gives you a nice little badge on your listing when you do become a member of the Academy. The accreditation, I believe, is $500, and the fellowship, I believe, is $500. And it's a test, one-time fee, take a test, and then once you pass it, you get the accreditation on your listing, and you can use it anywhere else as well. So this is a really great tool, and it just shows that you walk the walk, right? So this is really great stuff. I also wanted to just quickly review our membership options. So all of you that are not members, please do consider joining us. Right now it's $295 a year at the basic membership level. That comes with all of these things right here that you can see. And we're constantly growing, and I'm constantly looking for new people. If you are interested in some additional marketing materials like videos and promo materials and things like that, we do offer an advanced membership that comes with some really great videos and tools that you can use to help market your business, especially if you're an acting practitioner and you want to get the word out there. So come on over to this page and check that out. We've got some samples and videos for you to take a look at. It's really great stuff, and it's kind of a shortcut to get the message out about Biomedic dentistry to your patients and your future patients. Okay, I'm just going to look through my little checklist here to make sure I've covered everything. I believe so. Okay, so I'm going to pop back over to my slideshow, my slide deck one more time, and just give you the coupon code for today. Take a screenshot of this. So if you do buy for Dr. Sadr's next webinar on June 5th, will be your coupon code. Here's the time and date. And we are live now on the website. So if you do go to this URL on the website, you will be taken to the new webinar registration page that we just switched over from today's webinar registration page. I believe I covered everything. Mark, did I miss anything?
You did a great job, Matt. Thank you. The only thing I would add to that is for our certification track and fellowship track, we work very closely with the greatest minds of biomedic dentistry from around the world. And part of the qualifications for being certified as a biomedic dentist, since this is one of the most important things to keep what we're doing pure, is to be certified and make sure that everyone is doing it the proper way. We refer people to take courses by our scientific advisors, by the greatest minds in the field of dentistry. When you satisfy the CE requirements for the courses that we approve, that also goes towards the accreditation process and the fellowship process. So that's very important. And the $295 basic membership, I know from personal experience, you'll make it back in one patient just by people who look you up and go find you. I have people all over the place searching for biomedic dentists in New York City. And I'm beginning a ton of people coming in through the website just because they're looking for a biomedic dentist in New York City. So it's a great tool to have, not to mention all the vast information and material that we have as resources for everyone to watch and review and see case presentations. So it's a great thing to be a part of in a great community. So thank you, Matt, for talking about that.
Sure
and
thing.
Thank you to Dr. Sadr for an amazing, amazing lecture. I appreciate that. It was fantastic. I'm gonna have to rewatch that again. We're sending the link to everyone so we can rewatch if you've been a part of this. So a lot of questions came in. So I will start us off with a few questions that came through. and then we'll open it up so we can have a free discussion at the end. All right, so without further ado, let's go with a few questions. Someone asked, how long should we etch, and should we use selective or total etching technique? And what is the approximate time for application of a bonding agent?
Does that refer to silver diamond fluoride or in general?
I mean, I'm just reading the questions here, but I'm assuming if you're etching, how long do you etch for? There's different thoughts on how long to total etch for the phosphoric acid.
Yeah, so I'm not referring to total etching for self-etch adhesives. I was referring to silver diamond fluoride treated dentin, and our protocol in this case was 20 seconds after silver diamond fluoride application. So I think there were a lot of questions about that. So if you decide to apply silver diamond fluoride as an antibacterial agent prior to bonding, and you want to then use a self-etch or a total etch adhesive, my recommendation is to use phosphoric acid etching, the total etch, no matter what bonding agent, for 20 seconds. So rinse off SDF, total etch for 20 seconds, and go ahead with your bond. This does not apply to cases where you do not use SDF. If you're not using SDF, just follow whatever recommendation your manufacturer has. We're going to talk a little bit about that next week. Again, it is for SDF. After SDF, rinse SDF off, 20 seconds of phosphoric acid etching, rinse it off, and go ahead with the bonding steps.
Okay, another question is, when you try to seal a tooth with a difficult anatomy, whether it's the Coke bottle type of thing or a difficult anatomy, would you consider using a fissurotomy burr to modify the anatomy to help create a better seal, or just using the air abrasion?
That's what the books used to say. If you have the air abrasion, I would say I wouldn't touch a fissurotomy burr. If I don't have air abrasion, I might do that, even though I want to be very, very careful with micro cracks that we may create in enamel as we use fissurotomy carbide burrs. But so air abrasion is my choice, and you don't need to go with a burr again.
And types of air abrasion, you mentioned with the Aqua 4 versus like the Crystal Mark or other types of air abrasion. Any preference?
Gets into commercial. I think I think AquaCare is a pretty unique system out there. I don't know any other ones that have as many types of powders and combined water flow as well. But there may be other brands. I've worked with AquaCare. I like it, but of course we have Danville's micro etcher. It's been around forever, and that's also really good. But AquaCare is sort of unique in my opinion.
Ellie, just a quick comment. Although we both love the AquaCare for larger things, for the really, really teeny stuff, some of the, like the Crystal Mark and some of the other devices have a very, very fine nozzle that might be an advantage for the really, really minimally invasive fissures.
Correct. I think, what is that product from Texas that Dr. Rainey has? What is the brand? That has a very tiny nozzle. Anybody aware of that?
Sells his own thing, but there's also the Crystal Mark unit.
Crystal Mark, yeah.
Rainey's is his own brand, and you have to have 75 pounds of pressure when you run it.
Right. I couldn't hook that up at school. I have one of those. I couldn't hook it up, but I love the tip on that. The precision sort of nozzle.
It's a very, very good unit.
Yeah.
Okay, so people are also asking your protocol. You may have touched on it, but the protocol for your sealants using the etch and a bonding agent or not, or how do you do your protocols for the sealants? And then the question following that is a GI versus a resin for a sealant.
Okay, so the protocol for sealant, if you are using a resin-based sealant, I would bond it, even though traditionally we just etch and then apply the kind of flowable composite type sealant. But I would bond it and then apply the sealant. It's a little bit weird, I know, but you would get way better seal with the bond. So I would bond my sealants, but you need isolation for that. If you don't have good isolation, go ahead, use a Glassonomer-based sealant. And for a Glassonomer-based sealant, just need polyacrylic acid etching and application of the sealant. So that's basically the protocol. Again, if you have air abrasion, that's ideal, much better. Both cases, you can do the air abrasion before application of your pre-treatment.
Right. What are your thoughts about the ICON system for remineralization and sealing teeth?
ICON is a resin-based system. It does not result in remineralization. It does not release calcium or phosphate or fluoride into the tooth. However, we did several studies with ICON. It does decrease loss of calcium from your initial lesions. So it kind of sets everything like embedding in resin. So you would have less progression of demineralization rather than remineralization. We've had good success with smooth surface lesions. It's a little bit more technically challenging with interproximal lesions. So I would say I would wait for larger clinical trials on the interproximal. And I know that there are other systems looking into making Caries infiltrant, resin-based Caries infiltrant, bioactive one way or the other. But yeah, I like ICON. Wasn't the subject of my talk, and but it's not a remineralizing agent.
Okay. And there's a question asking, I guess it's another product question, but advising for Glassonomer, Triage, Equi, or another brand?
Triage. GC Triage is my choice, but it depends on your application. If you're using Glassonomer as your, say, filling material for a posterior tooth, then Equiforte is also great. We have Fuji 9. I still like Fuji 9, conventional powder liquid stuff. You're looking at RMGI's Fuji 2 LC is great. Yeah.
And another follow-up question is, how long can we expect the traditional Glassonomer to last on the tooth in the situation of caries control?
Sorry, is Glassonomer for caries control? They last.
Yeah, how long will that sealant last?
Oh, sealants.
Well, you're sealing with Glassonomer on the tooth to control
Okay,
caries.
so sealants last in terms of their, because, well, what the literature is telling us is a Glassonomer sealant lasts 2 to 3 years in terms of its retention. So it's a little bit less than resin-based sealants. But if you have a cavity preparation, they actually last a very long time. If you pre-treat that tooth with silver diamond fluoride, you're increasing the interaction of Glassonomer with the dentin. So that would actually even last longer. I don't know how many months, but I have seen 6 months, a year, 2 year of badly decayed teeth that have retained Glassonomer fillings. The issue that will ensue in the longer term is not actually secondary caries, it's fractures, because we're going to talk a little bit about crack stopping mechanism and all that. So I don't recommend them for permanent restorations without any sort of reinforcement or application of a composite. But for as long as you're in the caries control mode, there is absolutely no issue with them.
Okay. There's a question regarding the SDF asking if it can be used as a caries detector to search for caries in patients, and also can it be used preventively in high-risk caries patients?
Of course, you can use it preventatively in high caries risk patients, like a case that I showed that was followed up for 6 years. You can apply it to high caries risk areas in xerostomia patients and elderly patients and patients with dental anxiety, in patients that have dexterity issues in terms of their oral health care and all that. So all caries, high caries risk patients, you can apply SDF. There are some studies looking at SDF as a sealant, would basically or replace it for occlusal sealants. There are not a lot of information out there yet, but I know some people would swear that you can just put SDF on, and mildly demineralized fissures and it's going to work. So it's a great preventive product. What was the second part of the question?
Can it be used as a caries detector?
Oh yeah, I mentioned that. I think what Dr. Tagami has referred to is that as you're doing your excavation, you could apply SDF and maybe light cure it quickly to see that areas that are highly stained are areas of caries infected dentin. And that advantage is that you have also some antibacterial and rehardening effect. So it's sort of a bioactive caries detector dye, right? Are there a lot of studies on that? I absolutely don't think so. But experimentally, from people who have used caries SDF for over 50 years, right? The Japanese have used it for 50 years. They say that during excavation of caries, they sometimes use SDF and quickly light cure it as a way to recognize the infected dentin.
Cool. Someone's asking, if you apply SDF pretty liberally for areas of caries, would it burn or stain the tissue?
Liberally on, so that's a good question. Don't apply SDF liberally, basically, because it's going to stain everywhere. I think there was a slide that I showed its effect on the soft tissue. I may not have gone over what is slide showing. So if you're using SDF, please be very careful with its application. The application should be targeted. I cannot say that you can liberally apply it. I don't have evidence on that. But what I've seen is a lot of staining. Your countertop will be stained permanently and you won't be able to take it off. The soft tissue may be showing some white marks that may resemble sort of burning in there. So I cannot recommend liberal application of SDF. Be targeted, rinse it off. If you can get a good isolation, that's good. But yeah. And so there is a publication coming out very soon where we looked at the penetration of these ions into the pulpal space. So that is something you want to consider, especially if you have reversible pulpitis deep caries case.
Okay, and one more here. What is your criteria for choosing to apply SDF without excavation or with excavation and Glassonomer with regard to adding a composite to it? Would you apply without excavation? Would you excavate? I think I remember you covering some of that, but just as a question that was asked.
That's a good question. In cases that the caries is gross and I feel like I have absolutely no chance of saving so many teeth in such a short time, I would just do cleanup, very minimal excavation, apply SDF and Glassonomer. This doesn't apply to cases where I think I can get a better caries removal and choose Glassonomer or other type of material as my base, or even just go with composite. So rampant caries cases, hard to control cases, where the time is short, I would just clean it up, apply SDF and Glassonomer.
And just a separate thought as we're talking about this. If you have a deep area of cervical decay and you were to carefully apply the SDF and then do the Glassonomer in that area, if you were to create a mode of peripheral clean tooth structure around the area where you applied the SDF, could you then apply Ribond, seal up the area, and then build up with resin predictably?
You can certainly try that. I haven't done it, but if I had to think of a protocol over that, I would go apply my SDF in a targeted manner, right? And as I mentioned, I would still prefer to use Glassonomer, and then maybe in a second stage, I'll bring the patient back, do a little removal of the Glassonomer, not to the point that I reach completely to the dentin that is sort of healing, right? I call it healing the caries. This is at least one of the things that we can get out of SDF-GI combination, and apply Ribond and composite. So I would do it in 2 stages.
Okay. Well, I want to be respectful of your time. It's now about 20 after 6, so I figured that we should just, if you'd like, open this up to just a general discussion among us and say hello to each other and ask any questions out loud. Thank you, Ali, for an amazing talk as usual. And please, everyone, sign up. It's up and it's live. It's available now to sign up for his talk in 3 weeks. It's going to be incredible. And so please utilize that code and sign up for Dr. Sadr's lecture in 3 weeks. And let's open up to discussion for everyone.
Thank you, Ali. It was terrific. It's great.
Feel free to unmute yourselves and ask any other questions or just say hello to everyone if you'd like.
Ellie, how did you find a tie that matches the tree?
I've been proving since the morning.
It's true. I love the cherry blossoms. It's awesome.
Mark, I did throw a few more questions at the bottom of that list. I don't know if you saw those.
I did not see those. Okay.
I think the word is that you can go ahead and unmute yourself. If you want to say hi or whatever, you can do that.
Yeah, it's free. That's right. It's open mic time.
Hello, thank you so much for the amazing webinar. I'm Andrew from Egypt.
Hi, Andrew.
And doctor, I want to ask about what if you said that you would do a 2-stage protocol if you're gonna apply the rebond. What time do you delay in the second procedure, for 1 week or 2 weeks, and what the recommendation of the delay?
I would say the longer the better. In the case that we published in Operative Dentistry, we waited 6 months before we went ahead and applied the composite. So if you have that luxury of following up your patient for 6 months, you're going to allow the saliva, the Glassonomer, and the SDF to do their job, to remineralize and harden the dentin. Now you will be amazed when you go back in and you apply your fiber reinforced composite, because you're dealing with a tissue that is way healthier than when you applied the SDF-GI. At least 2 weeks, I would say.
Great, thank you so much.
Ellie, I had a tooth where I applied SDF. I hadn't known this at the time, very close to the pulp, and it got a bad pulpal reaction. Is there a limit there to proximity?
We don't have a number. Again, we're looking at that. So I would say if you're less than 0.5 millimeter from the pulp, you gotta be very careful with SDF. So if you're less than 0.5 millimeter and you have to apply SDF, I would say apply SDF, immediately follow with potassium iodide, because the potassium iodide does decrease the amount of ionic penetration into the pulpal space, and then wash it off. And that's why I say, if you're thinking that you're going to use SDF, do not dig a lot, because that's going to create issues with the pulp. And I have had a few cases like that too. That's why we just looked into penetration. So maybe something I forgot to mention in Yamaga's slide, when he said SDF will protect the pulp, I think what he wanted to say is that we'll protect the pulp by sealing the dentin and remineralizing dentin when you have enough remaining dentin thickness. You don't have enough remaining dentin thickness, do not apply SDF. Think ahead of time, apply SDF earlier, apply the Glassonomer if you have to, but do not get too close. Do not dig too much. If you dig, forget about SDF.
Thank you.
Dr. Sadr,
Yes.
can you hear me?
Yeah.
Hi, thank you so much for your lecture. This is Mama from California. And I have a quick question regarding silver nitrate. Would the efficacy be similar to SDF? And how about the protocol of application? I do have some patients that are very hesitant, very much hesitant about fluoride, especially for the kids. So what are your thoughts on silver nitrate instead?
Good question, Mama. I don't know how to answer this because I have really never used silver nitrate. As I mentioned, silver nitrate was the inspiration for silver diamine fluoride. I would imagine that the protocol is similar, and then you want to, but I mean, so here is the deal. Can you apply Glassonomer on those patients or not? Right? Because
Yeah.
it's going to be fluoride, right? If you can't apply Glassonomer, then I mean, silver nitrate is going to stain the teeth really badly. But it is antibacterial. I would say I would prefer to apply SDF. I do have those patients. Sometimes, you know, having a serious talk with them and letting them know that this is not a systemic fluoride, it's not going to get into your system. The amount that will get into your system is very little. That's why we wash and we completely remove the residue and all that. Sometimes that works. If it doesn't work, yeah, you can apply silver nitrate, but ethically, are you going to apply Glassonomer on them or not? That's the question.
That's okay. Thank you. Thank you so much. Makes sense.
Hello, Dr. Ali.
Oh, hi, Ahmed. How are you doing?
Yeah, it's very late here in Saudi Arabia. It's a pleasure to hear and see you. Just a quick comment about the SDF. I had some terrible experience in pediatric dentistry. And this is because, you know, in pediatric dentistry they are using it now like crazy. You know, every case, most of the cases now they are using it. Your meticulous studies and meticulous recommendation about using it, it's so inspiring, and it enlightened me so much. Okay, because I was so much, you know, most of the reports, even in pediatric dentistry, unfortunately, they are not telling us the precautions and the exact recommendation how to use this material. This material is very good. It has many advantages, yes, but how to apply it, this is the point. Okay, the point is that in pediatric dentistry, of course, the kid is not cooperating, so they just they remove, and also the size of the remaining dentin that is left from the already cavitated tooth is so small, and after you excavate a little bit, the effect of the dentin becomes very thin. And of course, this is the dental tubules are widened in this area, and they are just putting the SDF, and on top of it, they get this stainless steel crowns with open margins, and they just put it on the deciduous tooth, you know, and they are, you know, eliminating the remineralizing effect of the saliva, depriving it from reaching the SDF, okay, and putting the SDF very, very near to the pulp with a small effective depth of the dentin. This is literally what they are doing in pediatric dentistry. I had the terrible experience of extracting 2 of the teeth treated like that with one kid, you know. And the SDF gives very nice results for 2, 3 years, 4 years, 6 years of arresting the caries in many of the good conducted studies. But in this case, we got periapical abscess with swelling and all of these terrible things just within 2 months. So it's an excellent material, but it needs very meticulous selection of cases, meticulous application. It's not that it's not like magic. You will just throw it and it is antibacterial and remineralizing. No, it has. People should read the literature very well. Your results are very inspiring. There is, Muhannad, a very nice paper just released, I think, last month about its effect on the pulp. It is irritant to the pulp and it causes damage to the pulp if it is placed very near to the pulp. And as you were repeating this thing in between the lines during your whole lecture, that you have to be careful, This is red flags that everybody should see, and just use the material according to its recommendation and read literature, please, very well. Thank you very much.
Thank you, Ahmed. I think it's important to pay attention to these cases. I think I mentioned Dr. Momoi also when there was a slide where she shared her experience with SDF in Japan, and she had similar concerns. So I've heard elsewhere recommending SDF as a pulp cap material, direct pulp cap material. That is absolutely insane because it's poison, it gets into the pulp. If you're that close, less than 0.5 millimeter, I would say. And for kids, it may create a really bad experience. I agree with you on that.
Thank you very much.
It's just another tool in your toolbox. Is not what, I didn't want to get into the commercial stuff. It's not what you might hear in commercial stuff. No, it's not going to eliminate caries. It's not going to be your pulp cap material. It is not good for the pulp if it gets into the pulp. It is toxic.
Okay, Dr. Sadr, thank you for your amazing presentation. Do you hear me?
Yes, yes.
Oh, thank you. Thank you for your presentation. I'd like to ask you a question about the indications of the silver diamine fluoride. So can we say that it is only for non-cooperant children and elderly people?
And hard to control caries cases, rampant caries cases. These are other sort of indications.
Okay,
Yeah. So if you can reasonably remove infected dentin and have a good remaining dentin thickness with some affected dentin only, and you have good peripheral seal, then I would just follow my conventional restorative technique and will not get into using silver diamond fluoride. So it's not something I put on all the cases, unlike what some may think. And again, better way to restore dentin after SDF is with Glassonomer, because that's how it was designed.
Thank you. For example, with people who have cancer and a risk for necrosis and who have very damaged, very big carious lesions on the roots that are difficult to access, even with rubber dam and everything, can we just put silver diamine fluoride without Glassonomer, because we may have difficulties sealing it with the Glassonomer? So can we just use silver diamine fluoride and leave it, even though the caries is quite big?
Of course you can do that. And this case that I showed of my dear patient, which we followed for 12 years, he was told that he will need to remove all the teeth because of squamous cell carcinoma and removal of part of his tongue and all that. So what we did, we just applied SDF, we washed it off and we let him go. And he came back for annual application He kept a lot of his teeth. I should also mention, now that it's a more kind of friendly gathering, that in the very long term, silver diamond fluoride by itself may result in dehydration of the teeth. So you might see fractures over, over 10 years or something like that if you apply, extensively in the oral environment. So it has its own applications, like a xerostomia, cancer treated, chemotherapy, radiotherapy cases. It's great. It helps to improve the quality of life. But again, it has its own limitations. Yes, that's a perfect indication that you mentioned. Okay.
Yes, I had a question. After you do the SDF and the KI or not, and then you put the glass ionomer, when you come back to restore with regular composite, if you want to, do you leave a little bit of that glass ionomer against the dentin of the teeth?
Yes, I believe if you are following this technique, you don't want to get back to the dentin interface, because first of all, that's an ongoing process. It may still be kind of acting in there. Second of all, if you are exposing the dentin again, you might not be able to seal it as well with these. So there is really no reason to dig into the dentin interface. Just leave the glass ionomer. You're doing it for the aesthetics. You're doing it for function, whatever you want to do. Leave your glass ionomer on top of the SDF treated dentin.
Great, thank
By
you.
I don't know by how much. If you have OCT, you can measure the thickness. I would say 0.5 millimeter, 1 millimeter, or something of glass ionomer. I can tell you about my own tooth that has SDF in it. I have a third molar that has a pretty sizable buccal lesion. It's very difficult to access that area in American dentistry. They take these third molars out, but I don't want to lose my third molar. So I had Dr. Ches put SDF and GI on it a few years ago, and it's great. I love it. And it is so hard to see even that buccal lesion. So I think Dr. Ches just went kind of blind in there with the micro brush, washed it up, put the glass ionomer, and it's been really wonderful.
Dr. Sadr, Mamak again, I have another question. When we are prepping for, let's say, a class 2 composite, and we detect another like almost incipient caries on the adjacent tooth while we are prepping the other one, can we use SDF just more like a preventative measure on that incipient caries? And how do we know if it's actually working? Because I've had these cases that the radiolucency on the X-ray was to a point that I wasn't really sure if I should go ahead and access the tooth and do a filling, or should monitor. So when I was working on the adjacent tooth, I visually could see that there was some caries, but not getting to dentin. I applied the SDF, but how do I know if that really worked? Because regardless on the X-ray, the next white-wings is going to pretty much still look radiolucent, right?
Okay, so yeah, thank you for complimenting the information. I should have mentioned, right, yeah, that's a great application for SDF. Just be careful that it doesn't contaminate the area that you're going to restore with your bonding technique, because then you may need to modify your bonding technique if SDF is contaminating the tooth that you're working on. But that's something that I definitely do myself. If there is a questionable lesion on the adjacent tooth, I would go ahead and apply silver diamond fluoride there. I might apply, fluoride varnish or other things, but nothing works as good as SDF does in these cases. Mm-hmm. And another application is, of course, the open crown margins. We see a lot of them, old PFMs. You don't know what to do with them. You can't patch it. It's hard to reach. You can't replace the crown because the patient doesn't want it, or they can't afford it, or it's too much work. So SDF is great for arresting these lesions. It works. In order to make sure that it works, you got to take sequential radiographs And as long as it doesn't progress, it means that it's working. It's not going to remineralize the way that you want. You will see radiolucency go away. It won't. I mean, for that, you probably need to create a cavity and put some Glassonomer in there and all that. But just as a preventive method, I think it's a good idea. Follow up in a year or two. Make sure your patient doesn't go to a new dentist, because then they're going to dig into it because of the discoloration and the radiolucency. But that's a different issue with regard to documentation and patient retention. But anyhow, yeah, that's a good idea.
And as you mentioned, if the SDF contaminates the tooth that originally we were doing the restoration, we just change our bonding technique to using the total etch.
Correct.
Okay.
Or use Air Abrasion. Use Air Abrasion is going to remove that superficial layer, but a lot of, I think majority of dentists right now don't have access to that, so you would total etch.
Okay, perfect. Thank you so much.
Okay.
Open crown. Sorry, can I just ask this question? For the open crown margins you just talked about, do we have to put Glassonomer if we use silver diamine fluoride, or we just put silver diamine fluoride and we monitor it?
Well, if you have space and access, it's a great idea to put some Glassonomer in there. But most of the time, you don't really have an access, right? If you had access, you would, you would do some better quality, I would say, restoration. But you don't have to put Glassonomer. It's going to work even without Glassonomer. It's going to extend the lifespan of that crown for quite a bit. And it's so it's another, most of these crowns have already been root canal treated, right? So the pulp hole concerns are much less, and SDF is what a great application for those cases.
Thank you very much.
Okay, well, I'm gonna start to ask
Professor.
wrap it up. It looks like we might have two people who have raised their hands, maybe one or two more questions, Dr. Sadr, and we'll kind of end it.
Absolutely. I'll be around for as many questions as people may have.
Oh, that's great. So kind.
Professor, can you help me, please?
Yes, Juan, go ahead.
Okay, thank you very much. Compared to Theracal using the Thera technology with MDP and SDF, will act throughout a guide remineralization, or what will be the action?
You ask about Theracal?
Yeah. What is the difference?
Theracal is, I think, if I'm not wrong, isn't it a calcium hydroxide based material? So SDF is silver diamond fluoride, is antibacterial, and it is also releasing a lot of, so it's basically a solution of silver and fluoride, while Theracal is more like a if I'm not wrong, is it not a light cured calcium hydroxide based material? Yeah, it's calcium silicate, I guess. Actually, is it from Bisco, right? So they are totally two different animals. I mean, they are different things. They are different things. But I personally would go for the combination of Glassonomer and silver diamond fluoride because of the results that I've seen. Theracal is probably not as detrimental to the pulp if you're very close. So if you're very close to the pulp, you may want to choose Theracal as your base material. Does that answer the question?
Thank you very much, Professor.
About leaving Glassonomer exposed, I know the Biomedic study group, don't know if you know them. They're now losing their head because they hate leaving Glassonomer open, exposed to saliva.
And I didn't say you can do it forever, but I guess many of these cases, you really don't have an option of not putting Glassonomer in there. I mean, we don't have, if you're dealing with that 6 anterior deep caries cases, you have no other option. You can bring the patient back to do proper composite when you want to do that, but why would that be though? why would you not want to have Glassonomer open? Is it because of the material properties of Glassonomer?
Yes, I guess it's because of it dissolves in saliva on the medium term, and it might have mechanical properties that are different
Oh, of
from
course.
dentin.
Of course, of course. Yeah. I don't disagree with them. And that's why I say these are rampant caries control cases. So we of course know about disadvantages, a potential disadvantage of Glassonomer, but it doesn't mean that we should throw all the Glassonomer away.
Oh, yeah, no, I totally agree with you.
Okay. Going once, going twice. Is that it?
Doctor, do you recommend a special particle size for the Air Abrasion?
Good question. We didn't see a lot of difference between the 30 and 50 micrometer particles. I would say maybe 30. I don't know. I don't have research results on that. What do you recommend?
Coated materials work for all the indications.
Okay, everybody. I think that might be it. I want to say thank you once again to our wonderful guest today, Dr. Sadr. You were fantastic. Thank you for your generous time. Everyone is so appreciative of it. And we look forward to seeing everybody in 3 weeks, June 5th, 4 p.m. Eastern Time, New York time. All right. Okay, everyone. Signing out.
Thank you.
Thank you so much. Thank you so much.
Thank you.